Good evening. I'm Dr. Michael Smith, a member of the Montgomery County chapter of Alpha Phi Alpha Fraternity Incorporated, a member of Suburban Hospital's Board of Trustees, and also a member of Suburban's Community Health Improvement Advisory Council. Thank you for joining us for this evening's 19th Annual Men's Health Symposium, What to Watch For, a celebration of National Men's Health Month. By better understanding the unique risk factors that men face, we can promote healthier lifestyles and implement more effective prevention and treatment options for all men. As part of the hospital's commitment to care for the health and well-being of its community members, we hope that this evening will be an educational and informative webinar that you will enjoy and also utilize. We would like to thank the Frederick H. Boas Community Fund for their generous contribution to supporting men's health initiatives, including tonight's program. Without our valued community contributors, special events such as this annual symposium would not be possible. Tonight, we will hear from Gerald L. Andriole, MD, Director of Urology in the National Capital Region at the Brady Urologic Institute for Johns Hopkins Medicine on the importance of prostate cancer screening. And for those of you who are also looking forward to learning about atrial fibrillation, we have had a slight change in our program. Regrettably, Dr. Hassan will not be able to join us tonight due to an unseen scheduling conflict. We hope to reschedule his presentation later this year. So before we start, let's just review a few housekeeping items. All participants will remain on mute throughout the evening. You will be able to submit questions through the session at any time by typing in the Q&A box at the bottom of your screen. The questions will be addressed after the presentation. We're also recording tonight's presentation, and it will be made available in the coming days. Lastly, but certainly not least, your feedback is very important to us. It helps us build strong programming for future events. A link to our anonymous evaluation will pop up at the end of this program. We kindly ask that you take a moment to complete it, as it helps the staff at Suburban in planning for future programming for our community. Thank you. Now it is my pleasure to introduce Dr. Andriole. Gerald Andriole Jr., MD, is the Director of Urology in the National Capital Region at the Brady Urologic Institute for Johns Hopkins Medicine. A nationally recognized clinician and researcher, Dr. Andriole has made major contributions to the field of prostate cancer screening and treatment. Dr. Andriole received his medical degree from Jefferson Medical College in Philadelphia, Pennsylvania. He trained in surgery at Strong Memorial Hospital at the University of Rochester in New York and completed his urology residency at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Following this, he completed a fellowship in urologic oncology at the National Cancer Institute in Bethesda, Maryland. Dr. Andriole, thank you for joining us tonight, and the floor is yours.
Mike, thank you very, very much for the introduction, and Eleni and Kate for helping put this together. I really appreciate the opportunity to get to know some of our friends in the metropolitan area here. As some of you may know, I'm a new transplant to Sibley Hospital, having spent most of my career at Washington University in St. Louis. But what I thought would be helpful is to review a little bit about where we've been in the last 2 decades, really, with screening for prostate cancer. And I think if we take a good close look at what we've been doing, we'll all realize we need to do it a little better and a little bit differently. And so that's why I've titled this talk, Considerations to Improve Screening for Prostate Cancer. Now, the first thing that I have to point out is, if I could get my slide to advance. Now that's curious. Oh, there you go. There's a little bit of disturbing news here. This graph goes from the year 2005 through the year 2018. And these are data from the National Cancer Institute's statistical arm, the Surveillance, Epidemiology, and End Results Program. And what you see here are the proportions of patients who were screened for prostate cancer with the PSA test. And you can see it rose, it peaked around 2005, and then the proportion of patients in each of these age groups, 40 to 54, 55 to 69, and over 70, went down. And that's really a disturbing thing, because with the introduction of PSA testing and PSA screening for prostate cancer, the death rate from prostate cancer was reduced by about 30%. Now, as you would expect, this is data from a very recent analysis that just came out just a couple of months ago. As a consequence of the reduced screening for prostate cancer, you can see the proportion of newly diagnosed cases of prostate cancer that had distant metastases, that's what that word means there, it was falling until about the year 2012, and then it started to rise. Same thing here. M1 is another way of describing cancer of the prostate that metastasized to bones. The proportion of newly diagnosed cases was falling steadily, and then it went back up over the last several years. Same is true down here in the lower left-hand corner. These are patients who have spread to their nodes. You can see it was relatively stable, but in the last several years, it's gone up. And finally, this category means that the cancer, while it had not spread anywhere else, had invaded and grown outside of the prostate, often into the bladder and into the rectum. And you can see the same phenomenon. A higher and higher proportion of newly diagnosed men with prostate cancer went up. Now, you may ask yourself, well, why is that? Why are fewer men getting screened, with the result that more cases of advanced and incurable disease are being detected? We're going to get to it later, but hold on to this thought. There was a recommendation made by an organization called the U.S. Preventive Services Task Force. And that recommendation, if you can read the fine print on this slide, USPTF, U.S. Preventive Services Task Force, in 2012, as we'll talk about later, gave a D rating to screening for prostate cancer, as in, don't do it. So many primary care physicians and others stopped drawing PSA, stopped doing annual digital rectal exams. And we're now seeing the consequence of that in terms of these rising proportion of men who have advanced and incurable prostate cancer. So we've got to do something to stop that. And so I've been thinking about this over the last several years. I've kind of come up with these 5 strategies here. And that's what I want to talk about over the next few minutes, what each of these strategies involves and how implementing these strategies can reverse the bad news that's been developing lately. So the first thing, when you screen for prostate cancer, we should be screening and testing the men who are at the highest risk to get prostate cancer. And who is that? Well, men who have a strong family history of prostate cancer, their dad, their uncles, grandparent, grandfather, etc. African-American men have a very high incidence and a high mortality or death rate from prostate cancer. But over and above that, until fairly recently, we just didn't have good information on who was at high risk beyond those 2 factors that I mentioned. But then we did an important study, and I've highlighted here in the guidelines from an organization called the National Comprehensive Cancer Network. This is a National Cancer Institute, NIH-funded consortium of tertiary care cancer centers around the United States. And this recommendation right here, and I hope you can see the arrow of my cursor, talks about getting a baseline PSA. And then you can see the arrow from that says that could place you into a low risk or a high risk category. But let me tell you what we're talking about here. This baseline PSA we should draw early in life. So if you're a man, you have prostate cancer, you have nephews, you have sons, you have younger brothers who may only be in their late 30s, early 40s. That's the exact man in whom we should recommend an early in life PSA to establish his baseline. And why is that? Well, if you can read the fine print, the median PSA values for men who are in their 40s ranges between 0.5 and 0.7. Okay. Men who have a PSA above the median for this age group are at higher risk for prostate cancer and higher risk for aggressive cancer. And the higher you are above that median, the greater that man's future risk is for prostate cancer. And this graph is from a study that we did based on a population in Scandinavia. And the gray area here is the distribution of PSA results in all of these men who were between the ages of 40 and 49. And as you can see, most of the men, 40% of the men, had a PSA that was, well less than 1, probably at 0.5. But there were a considerable portion of men who had PSAs of 1, even in their 40s, and some who even had a PSA of 2 and 3. And what these graphs show, like for example, this blue line, is that if you had a PSA of 1 when you were in your 40s, follow that blue line, that man had a 15% chance of being diagnosed with prostate cancer sometime in the next 15 to 20 years. On the other hand, if that man at baseline in his 40s had a PSA of 2, which you might consider as normal because 4 has been the traditional cut point. Look at this. If I get my cursor to work again, if your PSA was 2, your next 15 to 20 year life risk for prostate cancer was about 25%. And if your PSA was 3, it's over 30% chance that that man would be diagnosed with an aggressive prostate cancer. And this just shows you the power of an early in life PSA to risk stratify men for their future risk of prostate cancer and to put them on alert that they really should get their PSA on a regular basis to see what's happening. Now, just hold that thought. I'm going to take a little tangent here, but we're going to get right back to what I was talking about, risk assessment for prostate cancer. The other thing that comes up, especially among older men like myself, is when and are there good criteria to stop screening for prostate cancer? And here's, again, data from the very same study among these Scandinavian men. And I'll just read the summary statement here. Men over 60 years of age who have a PSA of less than 1, and men over the age of 75 with a PSA of less than 3 have a very low future risk of metastatic or aggressive prostate cancer. So in that group of patients, if you are a man in your 60s and your PSA is still less than 1, it's very, very unlikely you're ever going to die of prostate cancer. You could probably stop screening. But that's just an aside, and it's sort of an interesting bookend to most of what we're going to talk about, which is about the early detection of prostate cancer in young men. But what other tools are out there now that can tell me as a doctor whether that individual man sitting in front of me in the office and having a conversation with me that can tell me what his future risk is for prostate cancer. We've talked about these three already: family history, African-American ancestry, and baseline early in life PSA. And there are all these other sort of esoteric things that I'm going to skip over. But I think the money shot, the most important next thing that we can do to help men know how risky their future is in terms of getting prostate cancer is to look closely at the genes that they've inherited and whether they predispose him to prostate cancer. Now, I know it always sounds concerning and complicated to start talking about genes and germlines and mutated genes and this, that, and the other. But let me just say that we are talking about the genes that you inherit from your mom and dad. And you can have inherited some mutated genes that are placed in the category of being highly penetrant, meaning if you have this specific mutation in this specific gene, you're almost certainly going to get prostate cancer down the road. And as I'll show you on the next slide, actually about 3% of all the prostate cancers in the United States occur in men who have these highly penetrant genes. And they may know they have it because guess what? It's the same gene that predisposes women to breast cancer. And you may have heard of the BRCA1 and the BRCA2 breast cancer gene abnormalities, mutations that predispose women to breast cancer. Well, their male relatives, if they have those mutations, also have a higher risk of prostate cancer. But that only explains about 3% of the cases of prostate cancer. A much larger proportion of newly diagnosed cases of prostate cancer that are inherited we can identify from what are called these low penetrant genes, which everybody has some of them, but it's not that one specific gene causes you to have cancer. It's just that a certain combination of these mutated genes can cause you to have prostate cancer. So these are the commonest genes, highly penetrant genes that men that predispose men to get aggressive prostate cancer. And I mentioned the BRCA2, BRCA1. There are these other ones there, but collectively, only 3 to 5% of all cases of prostate cancer. On the other hand, we can now do what's referred to, if you can see my cursor, a genomic risk score. Sometimes it's called a GRS, genomic risk score. Sometimes it's called a PRS, a polygenomic risk score. But it's the same thing. It's looking in most cases at somewhere between 30 and 60 genes. And if the pattern of gene abnormalities among those 30 is worrisome, that patient is given a high genomic risk score. I know this is getting confusing, but I think it's important. So if you look at all men who have prostate cancer in the United States, and this is one particular study, in this one particular study, only 1.5% of the cancers occurred in men who had these highly penetrant genes. Only 10% of the cancers occurred in men who had a family history of prostate cancer. But look at this, 25% of the cancers discovered in this series of patients occurred in patients who had these high genomic risk scores. So this can explain a larger proportion of cancer than just knowing your family history. And by the way, not every man knows his family history. He may not know who his father was. He may have been adopted, or many years ago, maybe his father and grandfather didn't talk about the fact that he had prostate cancer because it was not a pleasant conversation to have. So this polygenomic risk score And look over here, if you can see this, if an individual man has a high genomic risk score or polygenomic risk score, his chance of being diagnosed with prostate cancer is 75% higher than the average man, and his chance of dying of prostate cancer is twice the chance of the average man's chance of dying of prostate cancer. So it's a very powerful tool that we've just uncovered. And then this is the only commercial thing I'll have in my talk tonight. But this test is commercially available direct to the patient. You don't need to see a doctor. You don't have to have a doctor order it. It's called the Prompt Prostate Genetic Score Test. And if you're interested to know what your personal risk is for prostate cancer, you could Google that and get that test. If you've had prostate cancer and you're wondering whether your brother has, you may mention it to him because he may have inherited the same genetic abnormalities as you did. And even your children. If you have 30, 40-year-old children and you had been diagnosed with prostate cancer and you and your wife are wondering, gee, did the boys inherit this risk? You could get that test and kind of find out what the risks are down the road. This test, it's pretty powerful. This is a complicated slide about how it improves compared to the average, the risk factors we talked about: age, race, family history. PSA improves the ability to find prostate cancer. Knowing the results of this test is better. Knowing your baseline risk factors, your prompt score, and your PSA score is the best way of determining if you're at risk for a high grade or an aggressive prostate cancer. And the subject of aggressiveness, when this polygenomic risk score, and this is from looking at 24 different gene abnormalities, can stratify men who have non-aggressive cancers over here, all the way up to patients who on the basis of their score have a very aggressive prostate cancer. So it really is a nice tool to have in our armamentarium that, if we use it, can help us screen the men who need it the most. And that way we can hopefully reverse these disturbing trends of finding metastatic, advanced, and aggressive prostate cancer now that PSA isn't being used quite as widely. Second idea: patients and primary care physicians are confused about PSA. Why did I say that? This gets back to what I mentioned. I've got to try to go back. That the U.S. Preventive Services Task Force in 2012 gave PSA a D recommendation for don't do it. And that's when the proportion of men getting tested fell. But they've now revised that and gave it at least a classification of C that says you should engage in shared decision-making with a man about drawing his PSA. And at the same time, the urological community has done its share to confuse everybody, because we've proposed multiple different cut points. In other words, the level of PSA above which you should be worried over the last few years. So when we started screening at Washington University, where I had been, we used a cut point of 2.5. In Europe, they use a cut point of 3. PLCO, that's the National Cancer Institute's randomized trial, we'll be talking about that a fair amount in the next slide, chose a cut point of 4. There are age-adjusted cut points. Younger men should have lower cut points. Older men can have higher cut points because their prostates tend to be bigger. And there are race-adjusted cut points. African-American men, Hispanic men, all have different quote-unquote normal PSA values, and they're different among different races and ethnicities. So it is a very confusing thing. And the one way out of it, I think, is to just tell everybody to forget what we've been telling them for the last 15, 20 years and use a cut point probably of about 1.5 for referral to a urologist to see if that man has prostate cancer. And why is that? Well, we did some work in this PLCO cancer screening trial, which is a remarkable trial. We have been screening, we have 80,000 men in the United States who were randomized. 40,000 or so were getting screened for PSA. 40,000 were not getting screened for PSA. And we've now followed them for about 25 years. And I'll show you on the next slide that among all the men who started with a PSA of less than 1 early in life, this is sort of back to that very first graph I showed you, their risk for an aggressive prostate cancer over the next, it's now out to 15 years, as I'll show you on the next graph, is very, 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 very low, 0.5%. And there are other supportive data from that initial observation that we made in 2008 to say that the level of PSA at which a man has a considerable future risk for prostate cancer is probably somewhere between 1 and 1.5. And this is the data from the PLCO trial. So out to 12 years for the men who started with a PSA of 0.5 or between 0.5 and 1, look at the very tiny proportion of men who even 12 years later were found to have aggressive prostate cancer. But you can see if they started out between 1 and 2, it rose a little bit. And if they were starting out in the 2s, 3s, or 4s, it was commensurately higher and higher still. And a colleague of mine did a study a couple years ago looking at the performance of the PSA cut point of 1.5. And what he found was, this is in an HMO, the Henry Ford HMO data, 21,000 men who were followed for about 7 or 8 years. The men who had a baseline PSA less than 1.5, very low rate of prostate cancer, but it rose considerably if their baseline PSA was higher still. And if you do a statistical transformation of it, this curve is called an ROC, receiver operating characteristic curve. The best cut point, the best trade-off between sensitivity and specificity was 1.5. So that may be a way to clarify things among patients and doctors, that PSA of 1.5 and above is something to be worried about, and you should see a urologist and take some action. I'm not saying have your prostate removed, but you should take some action to look for prostate cancer. You know, we need to find, as we've been saying, prostate cancer earlier, not later. Not doing PSA results in later detection of prostate cancer. How are we going to do that? Well, number one, pardon me, this is a little bit jumpy today, is to choose a lower cut point. So again, this 1.5 cut point is the lowest of all the cut points that will have been proposed. But if any of you have had a prostate biopsy, you'll know what I'm talking about. We need to do a better prostate biopsy than we have been. If in the original dawn of PSA screening, we did biopsies of men's prostate in our office, and the patients were often squirming around, and we were doing the best we could to fire those biopsy needles into the prostate, hoping to hit the cancer if there was one in the man's prostate. But what we've learned is that that type of biopsy misses about half the cancers that are there. So it's falsely negative for about half the men who have cancers. And of the cancers it discovers, it mischaracterizes, usually by underestimating the size of the cancer and underestimating the aggressiveness of the cancer. So now, most recently, for the last few years, we've entered what I term the image-guided era of prostate biopsy. And what do I mean by that? Well, the first image-guided biopsy, and probably the most popular now, is MRI-based. So in my practice, and most urologists are interested in prostate cancer, if a man has a worrisome PSA, we order an MRI of the prostate. An MRI of the prostate is to prostate cancer what a mammogram is to breast cancer for women. If it shows a suspicious or an abnormal area within the prostate, we know that man needs a biopsy. And furthermore, we know exactly which part of the prostate to biopsy, because that's where the cancer is apt to be. And MRI of the prostate has been the gold standard, but it's not perfect. Here are, let's see, let me count them up, 1, 2, 3, 4, 5 studies that we reviewed that said the man had an elevated PSA. He got an MRI of the prostate. The MRI didn't show any abnormality. In what proportion of men was that normal MRI accurate? And the answer is, between 85 and 89% of the time. Turn that around, it says that if you're a man with an elevated PSA and a normal MRI, you still have a 10 to 15% chance of having prostate cancer that for some reason the MRI just did not detect. So MRI is good, but MRI is not perfect. Fortunately, now entering the conversation is a new form of ultrasound called micro ultrasound. And this is different from conventional ultrasound in that the probe images at a very, very high frequency, 29 megahertz. And this improves your image of resolution by 300%, by threefold. And you can see abnormalities down to the level of 70 microns. And we and others have looked at comparing MRI and micro ultrasound. So we did both in all patients. And what we found is that from a statistical point of view, we know that micro ultrasound is not inferior to MRI, because look, the sensitivity was a little bit higher, specificity was the same, positive predictive value was about the same, but the negative predictive value was better for micro ultrasound. And we are now doing a study that we're just now starting, where men with an elevated PSA will be randomized. Half of them will get an MRI and half won't. The half who don't get the MRI will get micro ultrasound, and we'll do micro ultrasound targeted biopsies first. And then if they do have an MRI, they'll be unblinded, and we'll also biopsy the MRI target. So at the end of the day, we'll have 3 groups of patients: those who've only had a micro ultrasound biopsy, those who had only over here an MRI guided biopsy, and those who had both micro ultrasound and MRI targeted biopsies. And we're going to see which strategy has the highest probability of detecting cancer, and if the detection is the most accurate. So this is ongoing right now. We actually got off to a little bit of a late start. First patients were just enrolled in February of this year. Fourth strategy: there's nothing worse than a man who has an elevated PSA, he gets an MRI, he has a biopsy, we don't find prostate cancer. What do we do with that guy? Did we miss the cancer? Should we biopsy him again? When do you stop? It's a conundrum. And the answer there are these what we call reflex biomarkers. And there are 4 or 5 of them that are very plausible. Some of them are based in blood, free PSA 4K score, and PHI, the Prostate Health Index. And 3 of them are based in urine. These tests can tell us whether a man who's previously had a biopsy, does he need to be rebiopsied? In other words, did the biopsy miss something? And when we looked at one of these, the 4K score, which is a blood test that includes PSA, intact PSA, free PSA, and -2 pro PSA, or HK2. So there's 4 separate markers. With the knowledge of the 4K score, we would have avoided rebiopsying 37% of the patients, and we would not have missed any of the worrisome cancers that were actually there. So it's another way for men who've gone through the gauntlet of MRIs, biopsies, there is no cancer, his PSA is persistently elevated. These reflex markers can really help him know whether he's got to still be worried or not, kind of thing. Final thing I want to talk about is what if we do detect cancer on a biopsy? Does every man need to be treated? And the answer we now know is no, because many of these cancers are very slow growing and non-aggressive. The problem is, until fairly recently, we didn't have really good tools to know exactly which one. Yeah, we could look at your cancer under the microscope and give it a Gleason score based on the appearance of the growth of the cancer. And that's a very useful way of characterizing how aggressive a cancer might grow or not. But you can often corroborate the findings of the biopsy of the Gleason score by, in this case, testing the genes that are abnormal in the cancer. Now, these are not genes that the man was born with, but these are abnormal genes that developed that then caused the man to have cancer. And for men who have what appears under the microscope to be favorable, low risk, non-aggressive cancers, if you got this test, you would corroborate that and find an additional 1 or 2 patients for every 9 men you test who you otherwise would have thought should have had some treatment, but now based on their genetic readout, they don't need to have treatment. And the same is true for unfavorable risk, but not to the same extent. If your Gleason score is high and it looks like an aggressive cancer under the microscope, these tests can change the decision to treat the patient 1 time out of 25, not as often as 1 or 2 out of 9, but 1 time out of 25. And I think it's helpful to avoid unnecessary treatment whenever possible, because as we know, the treatments have side effects and can really change a man's quality of life. So in summary, and I'm happy to answer questions, I think what we need to do to reverse the bad trends we're seeing is to aggressively screen the men who need it most. And we can figure out who that is by looking family history, race, early in life PSA, and their polygenomic risk score. We should use an earlier cut for referral. We shouldn't wait. I think it really should be around 1.5. An abnormal PSA should not result in an automatic biopsy. I think patients should have an MRI or a microultrasound and/or these biomarkers that we've been talking about. If it comes to the point where, on the basis of these secondary reflex tests, the man needs a biopsy, he should have a quality biopsy, not something the doctor does in his office with the patient squirming around, but a good biopsy under sedation. And then again, if the biopsy shows cancer, the patient should be counseled carefully, and some due diligence and thoughtfulness should be made to determine that the cancer truly deserves treatment before we're proceeding to surgery or radiation. So, wow, that was a fancy segue to that slide. That's all I have to say. I really appreciate the fact that I was invited tonight and that I could speak in this way, and happy to open it up to some questions.
Dr. Andriole, thank you so much for an excellent presentation. You've shed some light on a topic that was quite honestly confusing, a little bit confusing. We do have some questions in the Q&A box, and I just want to go over those briefly. The first question is from a gentleman, Alan Book. He says, I'm an 86-year-old, should I still get a PSA? And he sees his urologist once a year.
Well, you could use the cut points from that Scandinavian study I showed you that said if you're 75 years old and your PSA, if you're at least 75 years old and your PSA is less than 3, you could definitely stop. The other criterion that we use, and this is a little bit difficult to accurately predict, is what is the man's future life expectancy? If we had a good tool to predict exactly how long a man is destined to live on the basis of his cardiovascular disease, whether he has diabetes and any other risk factors, if the man has a 10 to 15 year life expectancy, at least, he could continue to be tested for prostate cancer. If a man's life expectancy is less than that, having PSA testing is usually not worthwhile.
Great. That was a question I also had from myself and my family members as to what time you should stop getting tested. Next question we have is from an attendee, and it states, does it matter where a man goes for a PSA test for baseline and later tests? I've heard that not all labs use the same methods for testing PSA.
You're spot on. There's about 5 approved ways of measuring PSA. There is one standard against which all of the testing is standardized, and that's the World Health Organization standard for PSA. But having said that, most people would agree that there's about a 7% variation between PSA labs. So in other words, if I had a tube of blood drawn right now, and I broke it up into 5 separate samples, and I sent it to 5 separate labs, I'm not going to get the exact same number at all of them. I'm going to get a cluster of numbers that are plus or minus 7% from each other. Now, the other thing you got to realize about variation in PSA is that in the course of the day, my PSA changes because my testosterone levels are higher at sometimes, some points in the day, and lower at others. And so throughout the course of the day, my PSA may vary by about 10 to 15%. So if I drew my blood 5 times throughout the day and sent it always to the same lab, I'm going to get plus or minus 10%. So when you put all of that together, most urologists or people who looked at this would say, to really convince yourself that a man's PSA is rising, because that's what we're all worried about, is a rising PSA, he should have 2 or more consecutive PSAs that are at least 20% higher than baseline. So just having one PSA value that rises by 20%, that gets your attention, but then you've got to confirm it. And if you can, take as much variation out of it as you can, have it sent to the same lab, have it drawn at the same time of the day. Don't have had a rectal exam in the doctor's office. Don't have had sex the night before. Don't ride your bike to the lab. Those are the things that spuriously elevate PSA.
Fantastic. Next question is, if a person gets the prompts test, who helps them to understand the results since the GSR isn't ordered by a provider?
Yeah, the report is pretty self-explanatory, and there is a genetic counselor who can help talk to that person about the significance of their findings. Now, there is an option when you obtain the order the prompt test to put in the name of your urologist or your family doctor, and they will also send that report to that person, and that person could help you interpret it and understand it. But there are genetic counselors available at the company where the testing is done.
Fantastic. We have a question from Mr. Paul Porolsky. He says, I am scheduled for a cystoscopy aquablation next month. I am 80 years old and had the biopsy with 4 of 12 sites were positive. What can I expect?
Well, now let's back up. So you say you have 4 sites, or 4 of the core showed prostate cancer. I assume they were relatively small and relatively non-aggressive. And I guess your urologist and others have felt that it is not necessary to treat the cancer, which is fine. The aquablation ordinarily is being done to remove or kill some of the prostate tissue so that you can urinate better. It is not approved, to my knowledge, as a treatment or a way of destroying prostate cancer. So it sounds like your urologist is recommending the aquablation to improve the way that you urinate, not so much as a treatment for the cancer that you have.
Dr. Andriole, I have a question that goes back to what you were saying about knowing like your family history. This is Mike.
Yeah.
So you said if your father, your uncle, your brother, that type of thing. But what if the positive family history is actually on your mother's side? Does that have the same effect as far as it being from your dad?
Yes. Oh, yeah. Pardon me. Yes. Not as much. First and second degree relatives. They're not as sort of penetrant, or whatever the word is. Blocking out on the term, but no, maternal risk for prostate cancer is a positive family history for you, and then you should report that. It's not as strong an indicator as the paternal side.
Understood. Another question, if you have a moment. There's some side effects, as we know, for treatment of prostate cancer that really impact the quality of life. Erectile dysfunction, libido, fatigue. Should there be concern about how these potential outcomes could impact a man's decision to be screened?
If some men have, not a complete understanding of those side effects. Those side effects sound terrible, and they are scary. In my view, I would say it's true that they exist, but let's find out whether you have prostate cancer, and then you will be in a better place to analyze the trade-offs. If in fact I tell you have a relatively large aggressive cancer that's going to advance if we don't do anything, then that might change how much fear you have of losing your erections, or of having some temporary urinary incontinence, or whatever the side effect is that you're worried about, because your perspective might change. If you had an aggressive prostate cancer and you're looking at your 12-year-old daughter and you say, I want to be alive to see her get married, you may not mind a certain element of urinary incontinence or lack of erections to achieve that benefit of being around to see her get married or something along those lines. So it can change your perspective if you know exactly what your personal status is and the necessity to be treated for prostate cancer.
Understood. Yeah, it's a choice between, sometimes it is a choice between life and death, and people have to put that into their consideration pattern. Dr. Andriole, we do have a few ladies in the audience tonight. Is there anything, and as you know, the ladies go to the doctors more than men, and also a lot of times they are the prompting for the men in their lives to go to the doctor as well. Is there anything that ladies should be on the lookout for to help encourage their mate, husband, spouse, significant other to take further action?
Well, you know, maybe when you get your mammogram, he should get his PSA. That should become a household rule, something along those lines. But you're absolutely right. Most of us don't like going to the doctor. We forget about that. Don't prioritize our health. We have some belief that we're invincible and we're going to be fine. Over and above reminding, you know, your husband or whomever to get his PSA, the other thing you can do, you know, is encourage, and most women probably do, a healthy lifestyle in terms of eating, drinking, you know, avoiding red meat, you know, a prostate cancer friendly diets, avoid a lot of dairy, avoid a lot of protein, avoid a lot of alcohol. Those three things are things men really, really like. That's about the most that I could think of it right now.
Thank you. Thank you. You mentioned during your presentation about, you know, the genetics and the different gene tests, the BRCAs and so forth that people have. And you also mentioned that, you know, African-American men are at higher risk for developing prostate cancer. Are there any factors that we know of, hormonal, environmental, or other explanations that why African-American population is more present or developing higher risk for prostate cancer?
That's a wonderful question, totally unknown. But urban dwelling African-American men have the world's highest incidence and highest mortality from prostate cancer. The genetic studies of West African men have generally not shown findings that suggest a significant genetic contribution to that very high incidence and high mortality. Other sort of experiments, if you would, you know, Asian men who moved from, this was specifically Japanese men in the 50s, who moved to the United States and live in California, had, you know, in Japan, they have very low rates of prostate cancer. But within 2 generations, without intermarrying and living in California, Asian men have the same incidence of prostate cancer as Caucasian men in the United States, without any change in their background genes. And it just goes to show you what lifestyle, diet, environment, how those 3 things conspire to cause some of these cancers. So it's possibly a combination of the 2, but I have a feeling it's the way we live that is the main risk factor.
Very good. I think we've addressed the questions that were in the Q&A panel. And it's almost time at 7:55. I'd like to thank you again, Dr. Andriole, for an excellent presentation. And I'm sure it will encourage our audience to get screened as appropriate, depending on their risk factors, age, so forth and so on. To our audience, thank you so much for joining us tonight. I hope you've learned a lot. I sure did. Please don't forget to fill out the link to our anonymous evaluation. That link should be posted in the Q&A or the chat so that you can get it and fill it out. We really need you to do that because it helps determine what programs we will provide for you in the future. We look forward to seeing you next June for our 20th annual Men's Health Program, and I'm sure it'll be a topic of interest for you and your family. So just double checking to make sure that link is posted for the survey. And it's getting sent out now. It'll be sent to your emails, Eleni was telling me. So again, thank you all. Dr. Andriole, thank you again. I really appreciate it. And to everybody, have a good and healthy night. Good night.
Thank you for having me, everyone. I appreciate it, Michael.